My name is Matt Lilly, and I'm an orthopedic surgeon specializing in sports medicine and total joint replacement. I'm going to go through the causes of knee pain and focus on the anatomy and the specific regions that can be symptomatic. The knee is made up of 4 bones, starting with the femur bone, which is the thigh bone, the tibia bone, which is the shin bone, the fibula off the side of the tibia, and the kneecap, which is the patella. And these bones in the knee joints, specifically the patella, the femur, and the tibia, are covered in what's called cartilage. And this is the lubricated surface on the ends of the bone that help the joint glide and give us our function. Cartilage is very important to the joints of the body because it allows motion and function. The important part about cartilage is it doesn't have any blood vessels. And when it gets injured, it doesn't heal. Cartilage is made up of about 80% water, and it gets nutrition from the knee fluid instead of blood like other tissues in the body. And it has 5 times less friction than ice sliding on ice. So it is a very good lubricated surface. Also in the knee are another type of cartilage, which are the meniscus pads, which live between the femur and the tibia bone. And these give support and stability to the knee, and they're a bit firmer than the regular hyaline cartilage, which is on the ends of the bones, and they can get torn. And like the cartilage, they don't have great blood supply and don't heal routinely. The ligaments of the knee help confer stability in the knee. And the main 4 are the ACL and the PCL, which rest in the center of the knee. And this confers stability in front to back motion and rotation. And then the MCL and LCL, the MCL being on the inside of the knee and the LCL, along with some other ligaments that is on the outside of the knee, provide stability from side to side between the femur and the tibia bone. And then there's various tendons, which are connective tissue that allow attachment of muscles to the bone and allow motion through the knee joint. And the important part about tendons, although they're outside primarily of the knee, they can get irritated and have inflammation with some of the many activities we enjoy. The other structures of the knee I like to talk about are the bursa sacs. And the bursa are a loose connective tissue around tendons and mobile portions of the knee that can also get irritated and inflamed. These are something we like to look at to ensure that they are not the cause of knee pain. Cartilage injury is a very important topic to discuss because it is one of the main precursors of arthritis. And once cartilage is injured, it's very difficult to treat, as cartilage does not heal in and of itself. And right now we do not have a great answer to replace cartilage. And what can happen is once cartilage gets injured, it can increase friction in the knee. Fragments can break off inside the knee and cause locking, clicking, catching, and most importantly, inflammation in the knee. And once that happens, with more swelling, more irritation, we get symptoms similar to what is in osteoarthritis, which is basic arthritis from what we call wear and tear. Arthritis is the body's reaction to this wear and tear. So there's more friction because there's less lubricated surface. Sometimes the bone can start articulating or gliding against the other bone, and this is because the cartilage is gone. So what I like to say is that arthritis and wear and tear of the cartilage is not like a plaque buildup on the end of the bones. It's actually more of a wear and tear, like brake pads wearing out on your car, and that you've just run out of surface that allows that motion. And this leads to either bruising of the bone, inflammation around the joint lining. It can tear the meniscus. So a lot of people who say, oh, I have a meniscus tear when they have wear and tear in their knee, actually are just having more of a symptom of a meniscus tear from the actual increased friction from the loss of cartilage. So arthritis can lead to bowing of the knee and changes in alignment of the knee. It can also lead to grinding, catching, locking in the knee as well. It's usually worse with activity or prolonged sitting or standing. And it actually causes loss of the joint space, or what I call the space between the femur and the tibia bone, because there isn't any more cartilage separating the bones. And we can see this on x-ray because normally cartilage is clear on x-ray. And once we know that there's no more clear space, we can tell that there's probably no more cartilage. And we also can look for bone spurs on x-ray as well. And bone spurs are a reaction to the increased friction in the bone from the arthritis. And this can also point out this type of problem. With this increased friction, we get more inflammation. and this can cause an arthritis flare. The knee can become very swollen and tender, and we can lose motion with this. There are other conditions, including rheumatoid arthritis, gout with uric acid crystals, and an acute injury that can cause similar type of inflammation. And that's why it's important to see your doctor to rule out these types of causes. After an injury in the setting of arthritis, it's important to remember RICE treatment. And this includes rest, ice, compression, and elevation. And along with this, I also recommend anti-inflammatories if your doctor says that you can take them. And these include non-steroidals like Motrin, Advil, Aleve, or ibuprofen, or even prescription strength anti-inflammatories including meloxicam. And these can all help decrease pain and swelling in the knee after an initial injury. And it is important to see your doctor in the setting where you're unable to bear weight on the knee, where there's increasing redness and swelling that isn't improving, and loss of motion of the knee. And if there's any pain or unstable feeling in the knee, it's also important to have this evaluated. And x-rays are very important for us because this can allow us to rule out problems like any broken bones, but it can also identify a setting of more advanced arthritis, and this can guide treatment. So I often get asked about braces and whether they can help with knee arthritis. And in the setting of unstable ligaments around the knee, they can be very helpful. They can also offload painful or arthritic portions of the knee. But if patients trial a brace and they feel it doesn't help, I say it's not necessary to wear, that it is really a symptomatic relieving agent. So other anti-inflammatories, as I mentioned, non-steroidals by mouth can be very helpful. Tylenol is a good anti-inflammatory. There has been a lot of press about opioids and their danger in our society, and it's very important to avoid regular use. And they can be helpful occasionally in acute injuries, but they should not be routinely used for arthritic conditions. Cortisone injections can be very helpful in the treatment of inflammation and arthritis. And they are very good at staying locally, and very little is systemically absorbed. The concern is that cortisone over time can damage cartilage. In the setting where there isn't very much cartilage in the knee, it is relatively safe. They shouldn't be used too frequently, but they can be very helpful in allowing patients to return to the activities that they enjoy or prolonging their pain-free function prior to a joint replacement. Knee lubrication injections can also be helpful in the treatment of arthritis and is a great non-surgical option to relieve pain. Many of the injections come as a series or a single dose of hyaluronic acid, which is the fancy name for these lubricating shots. And some are synthetically made, and some come from animal-derived chicken combs. And these can help decrease inflammation and support the cartilage of the knee and give up to 6 months of pain relief. And this helps lubricate and cushion a joint that does have some wear and tear. Evaluation of early degenerative changes of the knee with an MRI can be helpful. It can identify symptomatic meniscus tears, and it can also identify the amount of cartilage loss in the knee that isn't identified on x-rays. It's a good fluid-sensitive study, and it can find injured tissues this way. It requires no radiation, and it can be a roadmap for surgery, especially knee arthroscopy, which can allow a more minimally invasive way to treat damaged cartilage or meniscus. I also like to mention that it's important to discuss with your doctor preventing fractures and taking regular calcium and vitamin D and making sure your levels are healthy. Surgical treatments for arthritis include minimally invasive procedures, which include arthroscopy, which is what I like to call camera surgery. And it's a way of making small incisions on the front of the knee that allow evaluation of the entire knee and treatment of injuries within the knee. And this can be everything from meniscus tears, cartilage injury, to ligament reconstruction. It is usually an outpatient surgery, and more it has become controversial for arthroscopic treatment of advanced stages of arthritis. It can be helpful in early stages, especially with torn meniscus, but it is not as helpful in later stages where we're getting bone-on-bone arthritis and inflammation. That it can be only effective for short periods of time and not much better than the conservative treatments that I mentioned earlier. So another option for surgical treatment of arthritis is knee replacement or knee arthroplasty. And it is the only cure that we know of right now for arthritis. What it is it's a surgery that replaces the weight-bearing surfaces of the knee, the tibia, the femur, and usually the patella. and it places metal and polymer implants in lieu of our original articular surfaces. And these implants are usually cemented, but they can be pressed into place. And the metal implants are usually made of cobalt chrome and occasionally titanium. And then the polymer is a high molecular weight polyethylene. And many manufacturers make these implants, but their function is all very similar, and they allow flexion and extension of the knee. And these surgeries can reduce the amount of pain related to osteoarthritis. There are also partial knee replacements, and they're very similar with metal and polymer implants that are cemented into the knee, but they only replace one portion of the arthritic knee, either the inside, the outside, or under the kneecap. And they can be very helpful for patients with limited areas of arthritis because they do maintain the native ligaments of the knee and the native stability. So the total knee replacement removes the end-stage arthritic ends of the tibia, femur, and the patella, and it replaces the ends of these bones with metallic implants and a polymer surface which allows the metal to glide with minimal friction. And the longevity of these implants is thought to be over 20 years now. It's important to discuss with your doctor the preoperative planning and optimization of your health prior to this surgery. And this includes weight loss, health optimization, including managing blood sugars and blood pressure, diet and exercise, along with a preoperative visit to your primary care physician, which will allow you to get basic labs, possibly an EKG. It is also important to go to a total joint class, as this has been shown to improve outcomes and overall knowledge during the surgical process. For the surgery, you usually have to arrive several hours before surgery, nothing to eat or drink after midnight the night before. Anesthesia usually includes spinal anesthesia, possibly a nerve block, or even a general anesthesia, depending on what your surgeon and anesthesiologist feel is the safest for you. The duration of the surgery is approximately 2 hours. Surgery includes an incision over the front of the knee, and guides are used to make minimal bone cuts for a well-aligned implant placement. The ACL, meniscus pads, and bone spurs are usually removed. The PCL ligament can be removed or it can be maintained for stability. MCL and LCL ligaments are maintained, and metal implants on the tibia and then the femur are cemented, followed by a polymer on the patella. And lastly, a final polymer locks into the tibial implant, and this allows gliding of the femur over the tibia. And then a secure closure of the tissues is performed by the surgeon, and a sterile dressing is applied. There are many types of knee replacements from many manufacturers, and they all have very similar outcomes, and it's important you discuss this with your surgeon. Here in Central Oregon, we offer robotic surgery. It is not minimally invasive. It is not really a robot. It's a navigated implant placement tool that matches implants to a patient using a CT scan obtained preoperatively. Is it necessary? Not necessarily, but it is a very helpful tool that you and your surgeon can use to place a successful knee replacement. There's also the option of using patient-specific guides, and this is a similar idea to the robot as it utilizes a preoperative CT scan to create 3D printed guides that fit to the patient's knee and allow placement of implants. There is less intraoperative flexibility to adjust implant alignment, but it can also provide a very successful knee replacement. Standard instrumentation is the most utilized method of knee replacement still. It is the gold standard of knee replacement surgery today. It allows flexibility of implant placement. It gives similar outcomes with navigated surgery. The argument is that there is more variability in surgery, but there is no proven drawback. And many surgeons across the country utilize this every day for very successful outcomes. So a great question that everybody has is, what is the recovery going to be like? And it can vary from patient to patient. Significant swelling is usually present for the first 3 to 4 weeks. And most patients need to utilize a walker or cane for the first 6 weeks. Then after about 6 to 8 weeks, patients regain most of their motion of their knee. And at about 3 months, I say most patients will feel comfortable traveling and walking with minimal discomfort. Of course, there can be occasional pain from time to time, and this depends on activity level. But usually at about 6 to 12 months, most patients have reached their goals. So some of the common questions I get about the surgery are, will my leg be longer after the surgery? And the answer is no. Will my leg be straighter? The answer is often yes. Will my knee beep at the airport? That depends on patient to patient and implants used. But sometimes these implants can set off a metal detector, and your doctor will likely be able to help you with this. Will I be able to run on my knee? The answer is that it's important to protect this knee as long as possible. and the more impact we have on the knee, the more likely it is to wear out with time. So it can be quite difficult to run or jog, but the implant is definitely stable enough to support our weight. And that is a discussion you should have with your doctor. How long until I feel better? Usually, most patients are getting better by about 3 to 4 months. And this is a very gradual process over this initial postoperative recovery. But if you're looking to travel, be able to walk and play with grandkids or family, usually at about this 3 to 4 month window, patients will be successfully putting the knee replacement recovery behind them. And then how long does the knee last? This is something that we don't really know exactly, and it can vary from patient to patient. But we do know that it is in the order of decades, and we're looking at possibly 20 to 30 years. The polymers that we use these days are very, very strong, and they do not wear very much at all. So this is a great improvement in total knee replacement. I want to thank you for watching our presentation, and if you have any questions, please visit our website or give us a call.